My name is Susan Webb. I'm a clinical endocrinologist from Barcelona, Spain, and I'm specially devoted to patients with pituitary diseases. These are rare diseases, but they are often running for many years before someone thinks of the diagnosis and then refers the patient to an endocrinologist. A recent paper by the French group in Paris, published in European Journal, has just demonstrated that despite 20 or 30 years since other papers were published on registries of patients with acromegaly, the mean delay is often longer than 10 years. And that is really a bit dramatic for the patients, because it means that before the diagnosis, their bodies have been exposed to an excess of growth hormone or IGF-1 in the case of acromegaly, or an excess of cortisol in the case of Cushing's, or else they've had Hypopituitarism for many years. And if these diseases were diagnosed earlier, the long-term side effects or adverse events or persistent morbidity would most probably be reduced. So it seems tremendously important that the degree of suspicion of these rare diseases increases in primary care. It is obvious that primary care physicians cannot think of a rare disease all the time, but if you see certain key features, like, for example, in the case of acromegaly, someone who has severe headaches which are progressive, associated to excessive sweating, an increase in the number of shoes, let's say they increase their size, their shoe size, or they have to change their rings because their fingers have got larger, or else they've suddenly developed snoring or sleep apnea. All these things may be indicators of an excess growth hormone and therefore acromegaly. Another thing is the bilateral carpal tunnel syndrome, and of course the change in facial features with a more coarse and larger nose, bigger jaw, and separation of the teeth, apart from having more hypertension and more diabetes. So if you see a patient with these kind of symptoms, just think perhaps that he may have acromegaly, because once you think of it, doing the 2 or 3 hormone tests to confirm it is not so difficult, and then followed by a brain MRI. In the case of Cushing's or hypercortisolism, these patients would definitely benefit from having an earlier diagnosis. These patients, often when they're diagnosed, are very sick. They have hypertension, they have diabetes, they have central obesity, they're depressed, they have more infections, and hypercortisolism chronically also affects the brain. So these patients often complain of having memory problems, they can't concentrate, their executive function is reduced, and although all these things tend to improve after cortisol is controlled, by no way does it all return to normal. And often the patients complain of these permanent morbid situations, which no doubt would be less frequent if an earlier diagnosis were obtained. In fact, there is a very interesting paper from Denmark where they have control of all your visits to the health system from the moment you are born, and they have been able to demonstrate that in comparison with the 300 cases of Cushing's they had diagnosed in the last, 20 years, compared to 3,000 or even 30,000, it was 10 or 30,000, I think it was, patients matched for age and gender with the general population, with a healthy population. these patients had many more health problems, but what was interesting was that in the 2 years prior to diagnosis, they already had more problems, like more fractures, more vascular problems, myocardial infarcts, and infections. And that is telling us that they already had hypercortisolism, but it wasn't diagnosed until some time later. So these are challenges which we endocrinologists perceive, but we definitely need that primary care physicians suspect these situations earlier so that we can then confirm the diagnosis and decide which is the best treatment. Another situation, hypopituitarism. It may occur after traumatic brain injury, after meningitis, after a subarachnoid hemorrhage. And when this occurs, it's often not thought about. It's different from patients who already have a diagnosis of some pituitary problem. But in these other cases, it is often not thought about. And then perhaps during some intercurrent disease, like an infection, pneumonia, or whatever, the patient really becomes sick, hypertensive, hyponatremic, and then when you investigate the cause, you often find that these patients may have a lack of adequate cortisol secretion, inadequate for the stress situation of an infection, or they're hypothyroid. And in this case, TSH will be undetectable, so it won't be high as one would expect in primary hypothyroidism, which is obviously the most frequent situation, but their free T4 will be low. And of course, if you then substitute the hormones which are missing, these patients do much better. And most importantly, they won't die from an intercurrent infection, which still occurs if patients are not adequately diagnosed. And another thing that I would like to remind primary care and emergency room physicians is that if a patient has a diagnosis of adrenal insufficiency of whatever origin and he comes to the emergency room, that is really a really acute emergency, because that patient requires parenteral or high dose glucocorticoids immediately. If not, the patient may die. And that nowadays would seem rather terrible, because it's so easy to prevent if you think about the diagnosis.